this fall. But the good news is that you have Mondays off.
Oh, what?
Class will be Tuesdays and Wednesdays. Clinical will be either Thursdays or Fridays or Saturdays or Sundays. Okay? So Mondays will be a day of sleep and or study and or recovery.
How long does our class take on Tuesday and Wednesday?
I want to say it's like 8:30 to 11:30.
Oh.
Can we make that 9 to 12?
It used to be you had classes Monday and Tuesday and then Wednesday
Especially getting off work.
and then clinical. And I'm thinking, why in God's names do we do this in the middle of the week? Move it to Monday.
Yes.
So that would be better. That way the people that have weekend
3 days in a row without
have a
weekend
chance to get their paperwork done or study or whatever. Psych will have to be 2 full days because there's no way that we can do observations because what we want you to do is observation one day to the next to see if there's change in behavior. So psych is, I can't remember if it's 6-hour days or 8-hour days. I'll have to look at it. But that will be 3 weeks out of the semester. Okay. If you're in med surg, you probably will continue to do the 10 or 12-hour clinical day and then you brief it. So we'll figure it out. But
is it 2 8-week mini-mesters?
yes, it is.
So if we would need to do weekend clinicals for part of it, or are you doing it like you did this summer, like straight through with the same group?
No. Since it's 2 mini-mesters, if you want to do clinical on weekends or need to do clinical on weekends or are willing to do for part of it,
Okay.
let me know. Psych will only be Thursdays and Fridays.
Sure. I can make arrangements.
But just shoot me an email and Rumble and I'll work it out. Because typically she does coordination for 114, which is the course we do first.
Okay.
And then 212 I do, which is the course that's from like your fall break to Christmas. So.
Are we okay with, I don't know if that's what she just asked, but like, can we stay with the same groups again? Because that's been really nice. Every other semester I've been running around to like every clinical instructor.
We try to do consistency because it helps not only you, but it helps us. Because if I only see you one day, how am I going to do your final evaluation when you may have had a bad day the week that you were with? We try to do consistency as much as possible. But with the psych, you will have to rotate because only myself, Ms. Rumble, and Ms. Chandler do psych. Okay? But we will try to get it as consistent as possible. And especially whenever we do spring semester. Consistency is the key there. Yeah, I don't like seeing people 1 week because God knows it's hard enough to learn your names when you're there more than 1 week, especially when I've put 2 Ambers in my group at the same time. All right, which Amber? Okay, so now let's go back to Parkinson's. Treatment of choice for Parkinson's disease is drugs, medication, and dopaminergics are the drugs that you're going to see most often, either the anticholinergics and dopaminergics. What they do is change the neurotransmitters that are produced in the brain. The actions are to either block the uptake of acetylcholine at the postsynaptic cholinergic receptor sites or elevate the functioning levels of dopamine in motor regulatory centers. All right, so what happens is acetylcholine and dopamine use pretty much the same receptor sites. So if acetylcholine takes that receptor site, then dopamine is blocked from taking it. So what we want to do is to decrease acetylcholine and increase dopamine. Because the dopamine, lack of dopamine, or the breakdown of dopamine is what's causing these patients to have symptoms. Now, what we typically are going to see is dopaminergic medications. Well, think about this. This is a carbidopa, levodopa, dopa, okay? It is a precursor to dopamine. Well, why can't I just give this patient dopamine? Well, because when you give it orally, the stomach acid breaks down. So carbidopa, levodopa is a precursor to dopamine. Once it is in the body, it converts to dopamine. So what I'm doing is stimulating those dopamine receptors, and what you are going to see is more coordinated movement. Typically what you will see is the ability for this patient that's on this med to function more normally. More smooth movement, less tremor, less problems with posture, less trouble with that facial drooling, less trouble with swallowing. So, when do I want to give this patient this medication? Right away. Whenever it's scheduled. This is one that I definitely keep on schedule. Typically, we give it about an hour before meals because it will improve the ability to chew and swallow. Usually about an hour before meals. Now, one of the things you need to know is that this is not the cure-all. What you often see is that whenever patients start on these meds, it takes maybe a month or two for them to have full effect of this medication. So it's not an immediate response. And like a lot of medications, they become tolerant of these meds. And so doses have to be increased. It improves mobility, decreases muscle rigidity and tremor. Those are your dopaminergics. Your MAO-B inhibitors. Okay? Stelazine basically inhibits the enzyme that inactivates dopamine in the brain. It can be used alone or it can be used with levodopa. Typically what you will see is they will do the carbidopa, levodopa for a while until the dose gets to this higher level. Like every other medication known to man, the higher the dose, the more side effects you're going to see, guys. So typically what they would do is after they've been on that carbidopa, levodopa, and had to go up on their dose, they may add stelazine. So what you will see is it has a synergistic effect. Basically what this does is it makes that carbidopa work longer and stronger because it inactivates the enzyme that breaks down dopamine. But this only lasts for about 1 to 2 years. And then it becomes ineffective. That synergistic response that you see from giving them goes away. Now, be careful about this one. It causes orthostatic hypotension. And I've already told you that my patients with Parkinson's have orthostatic hypotension to begin with. Change position slowly, or they're going to be DFO'd on the floor. You may see hallucination and confusion with this med in higher doses. Hallucinations are not a normal phenomenon for Parkinson's disease, and it's often due to med effects. Again, it's especially important to take at the time and at the dose that is prescribed. One of the things that you'll see with these meds is that you have to be careful with, you start low and go slow to bring them up. Because we already know that these meds are not going to be effective for very long. So we don't want to give them at the highest dose to start off with, because what you're going to see is it works a less amount of time. Dopamine agonist. Now, I know you've seen these in the news because their commercials are out there. Paramidex or Finerol, like Requip or Miracaps. You may see Requip used with conjunction with a lot of your antipsychotic medications too, or your antidepressants. What it does is it activates dopamine receptors in the brain, and it's frequently used with levodopa. What you will see is that, again, this is a synergistic effect. It increases the therapeutic effects of dopamine and will reduce the fluctuation. It's most effective the first 3 to 5 years of use. So again, this one has a timeline. And cholinergic drugs, benzotropine or cogentin, basically what it does is it blocks acetylcholine. Acetylcholine is an excitatory neurotransmitter. So what it does, this med does, is it chills out the effects of acetylcholine. So you get more smooth movement. Used early stages, or it's often used when they can no longer take the levodopa. Often you will see these anticholinergics. It eases the drooling, the tremors, the rigidity. However, you have to be aware of side effects. Anticholinergic medications, as a rule, cause urinary retention. Y'all know the little poem about anticholinergic toxicity? That's right. Can't see, can't pee, can't sit, can't. Okay? Those are your side effects of anticholinergics. It causes double vision or blurry vision. You can't pee. It causes urinary retention. You can't sit, meaning you're wiggly. And can't poop. It causes constipation. Okay, so people that are on anticholinergic medications, you have to be careful, bowel and bladder. Remember, my Parkinson's patients already are prone to constipation anyway. So you need to make sure that you have these patients on a bowel program with stool softeners, increased fiber, increased water to make sure that they're going regularly. Yes?
So, is a Parkinson's patient essentially going to run out of medications?
Yes.
At a certain point, there doesn't have to be that they can do.
Well, there is one thing that we're going to talk about in just a minute, and I'll tell you what it is. And that's this, called the drug holiday. Oh, are we going on holiday? What is that? Chicken Run? I love that. Basically, drug holiday, they will hospitalize these patients during drug holiday. Basically, they receive no drugs whatsoever for 10 to 12 days. So you can imagine what the effects of that is. The Parkinson is full on going. Okay? So you're going to have the problems with the freezing, you're going to have problems with the slow movement, you may have problems with swallowing, the drooling, etc., etc. Because what we're doing is cold turkey them off of these meds. And typically with that 10 to 12 day period, if you cold turkey them off medicines, you can then start them again at lower levels and you will have some effect. Okay, it may not be full effect, but you can start that. Now, just because you're doing this drug holiday doesn't mean that you get, it's like a do-over in golf. Yeah, you don't count that stroke and it just goes. No. Basically, what you're going to see is drug holiday may work in some of the earlier stages. But as you've been on these medications for longer periods of time, what you're going to see is that the effects are not going to be as bad. And typically, what you're going to see is that when you progress through those stages of Parkinson's disease, then the drugs are not going to be effective at all. Okay? So drug holiday, you might see with patients that are in some of the higher levels of these medications, and they're starting to get side effects from the meds in addition to their Parkinson's syndrome. Bring them in the hospital, cold turkey them, and then you gradually start those meds back. And hopefully you will get some of that. Okay? But typically they are hospitalized because they've got uncontrolled symptoms and they're not able to handle them at home. Okay? Not usually. It's used whenever you may be in early stage, say for like 2 years into your meds. Well, you've had to go up on your meds to control your symptoms. And so what happens is that they do drug holiday and then they can start at lower levels and then progress up to control some of the side effects. If you look at the video of Michael J. Fox, whenever he was testifying to Congress, one of the things that he did is that he took himself off those medications with his physician's permission. And you saw the movements that he was having during that testimony because he wanted Congress to see what untreated Parkinson's was like in order for them to provide research. Because it is a drug that you're going to see a large population with. As our population ages, the incidence of Parkinson's disease is going to greatly increase. Okay? But drug holiday, often you will see about 3 to 5 years into their treatment, and then maybe again in another 3 to 5 years. But as the disease progresses through those stages that I've listed for you, basically drug holiday may or may not work. Okay? Some of your interventions with that freezing gait and postural instability, they're major problems. OTPT, we've had good results with yoga or Tai Chi with people that are very much into doing things on their own. Yoga has been shown to be as effective as physical therapy with these patients. It's sort of like whenever you push someone to do something. It's like if you don't use it, you lose it, so to speak. the more independent, the more active that these people are, the less effects that they're going to have if they take their medication on a regular basis. But keeping them as functional as possible is going to be the best way to treat the patient. Now, there are a couple of other things that you might see done. Palidotomy is a treatment where they go and make lesions in the globus pallidus, which is an area that produces acetylcholine, or the enzyme that breaks down the dopamine. Palidotomies have been done for several years, and they are somewhat effective. The brain stimulation is like a pacemaker or a neurostimulator that basically does pretty much the same thing. And that's gotten some very good results too. The other thing that really is exciting is stem cell transplant. With the lifting on the ban for stem cell research, there have been some good stem cell studies with patients that have had Parkinson's disease, and they've had relief of their symptoms, because what they did is place these stem cells in the basal ganglia. They became basal ganglia cells and started producing dopamine. So we've had some good results with that as well. But it is not a treatment that everyone, either of these three treatments is not something that everyone can undergo. Usually those are only done at major research centers, and most of the stem cell transplants and palidotomies are done in California. I think we're waiting to see what the results of those are going to be before it's more of a global treatment. Now with nursing care, these are going to be your priorities. Impaired physical mobility, impaired verbal communication, imbalanced nutrition, less than body requirements, and disturbed sleep pattern. With impaired physical mobility, PT results, we're going to request that physical therapy teach caregivers how to do that range of motion, PID, or ask the caregivers to walk that patient at least 4 times a day. Okay? We want to keep them up, keep them moving. And it may just be a simple walk around the house or walk around the hospital hall. It doesn't have to be a hike in the Blue Ridge Parkway. Okay? We want at least a block worth of walk so that they can get them up, get them moving. Assistive devices like lift chairs, canes, splints, or braces from occupational therapy to keep that person as functional as possible. And we want to promote mobility, but safe mobility. Remember, falls are going to be an issue with this patient. Unassisted ambulation in that second stage puts this patient at risk for a fall. Impaired verbal communication. Remember, we've got that patient with that masked face, okay? So that a lot of our nonverbal clues are gone. Because whenever we see someone laughing or smiling, okay, remember a smile can be, or one of those evil smiles, and you're thinking, I better watch out for this person. But with Parkinson's, you don't get that facial expression. So impaired verbal communication is going to be one of those things that you're going to see. Speech, hearing, and writing. Speech therapy needs to be consulted as well. We want to develop an appropriate method of communication, whether it be a whiteboard, but remember, if you've got a patient that's got Parkinson's disease, writing may not be an option or that's very clear. So it may be picture boards or some other alternative form of communication. Remind them that because they tend to whisper or they don't have that ability to protect their voice, have speech therapy work with them in order to project, in order to be able to let their needs be known. Remind them to speak louder. In those first couple of stages, they will be able to do that, but not later on. Typically, what you will see is that they will have that low, monotonous voice. All right, think of, I don't know if you've ever watched Ben Stein from The Wonder Years when he talked about the world is 150 years old. You know, no inflection whatsoever. It was just very monotonous. And it was one of those droning things that just went on and on. Inflection that you get a lot of verbal cues from usually. These patients will not have. It's a very low, monotonous, with no lifts and falls of their voice. So you really can't tell if they ask a question or not. Okay, because whenever we are asking questions, our inflection goes up and we end. And so when you get that verbal clue, oh, they just asked me something, so I need to pay attention and ask them again what they asked. Okay? You will not see that with your patient. Imbalanced nutrition, swallowing precautions. Swallowing precautions. Swallowing precautions is a KDOD. Number one cause of death in your patients with Parkinson's disease is aspiration pneumonia. With imbalanced nutrition, basically one of the things that we're going to do is maybe do a calorie evaluation. How much are they taking in? We need to increase their fiber to decrease that constipation. We want to weigh them and record that weekly. Remember that you might have to alter their foods with that thicket where they don't get thin liquids. You may have to puree or grind meats or vegetables because the ability to chew is decreased. So those are some things that need to be thought about. And we need to make sure that their caregivers know that typically we don't want to supplement these folks with B vitamins because B6 is one that we want to avoid with the medications that they're on because it activates the dopamine. Disturbed sleep pattern. Teach them how to modify the lifestyle activities. Milk at bedtime. That wouldn't do anything for me. Diet, adapt environment. I mean, a lot of times what you'll see is that cooler, darker room is more conducive to sleep than one that has a lot of light source. Okay? If there's a light that shines in the bedroom, those blackout curtains are the best invention known to man. If you've not ever experienced them and if you work nights, I would suggest going to Bed Bath & Beyond and investing in them because they block all light and it's like the pit of darkness when you try to sleep. And it only costs you about $20 and it'll help your sleep tremendously, I can tell you. Typically what you see is that we don't like to give a lot of sleeping medication, but occasionally they will give something that's fairly mild. Some of the anticholinergics, or muscle relaxants sometimes will cause a sedative effect, and that may be enough to help sleep. But one of the things you have to remember is these people in later stages do not turn in bed. So movement is going to be a problem, and you may have to disturb them to turn them every couple of hours. Psychosocial support. Remember, we've got impaired cognitive function and memory, and those are fairly common. They're part of the disease process. Social workers, case management, because financial concerns may be an issue if they've been the breadwinner in the family. Because early stages, they may be able to work depending on what kind of work they do. If they're a construction worker or work heavy equipment, no, because of these medications. But if you've got someone that has a desk job, they may be able to continue to work. Placement may be a problematic issue, especially for people in the later stages. Remember, these are sometimes elderly clients with elderly spouses or caregivers, and often you will see patients that are not unable to be cared for at home. Final stages of Parkinson's disease, definitely palliative care consult. These patients are very appropriate for hospice care or for palliative care consults, because it is, in that fifth stage, a terminal process. As I said, the majority of these patients do die because of infection, overwhelming pneumonia or urinary tract infections. That causes them to become septic, and they typically die. It's not the Parkinson's that causes the death, it's the effects of the Parkinson's on the rest of the body. Any other questions about Parkinson's disease? All right, let's do muscular dystrophy, and then we'll do a quick overview. And then this work. Now, muscular dystrophy, what I'm going to tell you guys is there are 30 or 40 different types, but the one that you need to worry about is Duchenne's, because that's the one you're going to see most often. It's the most common form of childhood muscular dystrophy. What you see is a pseudo-hypertrophy, okay, of the muscles. It's not that the muscle itself is getting bigger because of use. The muscle gets bigger because of infiltration with fatty tissue. Okay? So typically one of the signs that you will see is enlarged calf muscles or arm muscles or leg muscles with these patients because of that infiltration with that fatty tissue. It is genetic. It's X-linked. So it is only seen in males. Okay? Females are carriers. You may also see Becker muscular dystrophy. It's also sex-linked, but it's very much milder in form. What I'm going to talk about mostly is this Duchenne. Generalized muscle weakness. Typically what you're going to see is a child with delayed development. They have delayed walking, they have frequent falls, they're easily tired when running, walking, climbing stairs, and they toe walk, meaning that most of us do heel-toe when we walk. But these kids walk on their toes. Okay, whenever you see a child that walks on its toes, they need to be investigated. It's either this or it can be tethered cord. So we need to be very careful about that. They waddle, and they have what we call the positive Gowers maneuver, and I'll show you that in just a minute. Their serum creatinine kinase is elevated. Why is their CK elevated?
Muscles.
Muscle breakdown. Okay, that is what you see. Diagnosis is done by muscle biopsy, and what that does is it measures the dystrophin, which basically breaks down the muscles. They also will do genetic testing, okay? Because if there is one child with MD, the chances are at least 50% that the next child is going to have as well. Now this is Gowers maneuver, where the child is on the floor, they come to this position, they move up like this, and then they use their hands to walk up their legs to stand to an upright position. So Gowers is when they're on the floor and they walk up to try to get in that upright position. Muscular dystrophy, nursing management, basically what you do is get them tuned into OTPT speech, home care, everything known to man in order to care for these children. Because typically what you're going to see is this child is going to be wheelchair dependent by early teens.
I took care of a kid that happened, who was 18 at the time, and he was in a motorized wheelchair. I had to go over and get him ready for school every morning. He had a 4-year-old that went off, just had a little bit of skin in his feet, on his hands, and actually his older brother had died from it as well.
Yeah.
And he had another older brother that did not have it. He had like one of the shaking vests, he wouldn't do that, like he just was to the point where he didn't want to do it, and his therapies for it, he had like a breathing mask and everything for at night, because he was like breathing at night, he just didn't want to do anything.
And she's just talking about old nursing care, okay? Typically what you're going to see is there's no effective treatment for it. It is a progressive neurodegenerative musculoskeletal disease, and typically they die from respiratory failure. What you find is that sometimes they will do prednisone and Delasort to preserve muscle function, but it doesn't work very well. Respiratory infections are vigorously treated, and what she's talking about is the shaking vest. It's a vest that they're put on there. Back in the old days, what we used to do was chest physical therapy, where you would take and just pop, just hit their lungs and turn them this way and turn them that way and drain their lungs and all this. That shaking vest does that for you. You just put it on, plug it in, turn it on, and it just jiggles the lungs to help get rid of secretions. Yeah. They use it with your patients with physical therapy, they use it with pneumonia. Patients with cystic fibrosis, they will use those as well. They're the greatest invention known to man, because they help make sure that they do their SPT on a routine basis. Promote safety, child and family support, but you want to maximize independence, okay? Remember, this is a child. This is a child that is going to die because of respiratory failure. Family support is key, but you want to maximize as much independence for that child as possible. Making sure that they're in social groups, because that's what the child needs at this point. Taking them to regular school until they're no longer able to go to regular school. Making sure that they're as independent as possible for as long as possible. Preoperative care when surgery is required, definitely we're going to make sure that those lungs are tubed up and that bladder is free of infection before any surgical treatment's done. Occasionally, they will do tendon releases to help with some of the contractures. But it is a post-op course that is often fraught with a lot of problems because they don't have the muscles to have good, adequate respiratory function. As she said, the shaking vest, CPAP at night, or BiPAP, because what you see is often muscles that are paralyzed or very weakened, so you don't have good diaphragmatic chest movement. So you will have impaired gas exchange, you have ineffective airway clearance, all of those things that have to do with the lungs these children develop. Okay? Making sure that there are as tuned into as many resources as possible. Muscular dystrophy is one of those things that there's been a lot of research, but unfortunately the research hasn't gotten us very much anywhere. But one of the things I will tell you is that we are seeing children that are living much longer. Like she said, her client was 18.
Yeah, it should be in this 20s.
Yeah. But when I first started nursing, usually these children only live to the age of 10. So we're seeing longer lifespans, but with much more disability.
I'm just saying, what kind of quality of life after that, 10
and
to
that's
14 years?
Not for me to decide.
Right.
That's for that family to make that decision. Okay? And then I support them with whatever decision that they make, whether I agree with it or not. And that's the hardest part of nursing, guys, is keeping your mouth shut whenever you totally don't agree with what their decision is. The hardest part of it. But you support that family with whatever decision they make. Questions about those things? Okay. I do not have a quiz, but I will give you some clues. I have almost finished this test. There will be at least 4 pediatric math questions that Ms. Ward's coming in to talk with you about in just a few minutes. I want to say for amputations, I've got about 12 questions. For MS, I think there's 10 or 11 questions. Parkinson's, maybe 14 or 15. Muscular dystrophy, I think 7. And it's mostly think about nursing care and meds. Because if you think about Parkinson's and MS, I spent quite a bit of time on medications. So think not only about which meds you might give, but what you give them for and what are some of the side effects that you've got to watch out for. Okay? With amputations, think about what kind of care that we went over, with that residual limb. What am I going to be looking for? What am I going to be doing to prevent contracture in that patient? What am I going to be doing to make sure that I have a good, well-rounded residual limb for that prosthesis to fit in? Okay? So think about those types of things. Nursing care and meds. Any other questions that I can help you with? Okay, I am going to go get Ms. Ward. Y'all take a break and be back at about 10 after. Those of you that have not reviewed your test, I'll be here after class and you can take a look at it so that you can take a look